Welcome to the PD Exchange, the Peritoneal Dialysis podcast, where we discuss the most recent and interesting peritoneal dialysis literature. I am your host, Dr. Nikhil Shah. I am a nephrologist at the University of Alberta in Edmonton, Canada, and with me, as always, is my co-host, Dr. Jeff Pearl. Dr. Pearl is a nephrologist at St. Michael's Hospital, University of Toronto, Canada. He is also the editor-in-chief of Peritoneal Dialysis International, the official journal of the International Society for Peritoneal Dialysis. Today, we will focus on pregnancy in ESKD population, which was the focus of the May issue of Peritoneal Dialysis International. To discuss this important topic, we welcome two experts who are active in this field. Dr. Michelle Larunovich, Professor of Medicine and Nephrology at the University of Toronto, and Chief of Medicine at Sunnybrook Health Sciences Center. She is also the founder and co-lead of the Sunnybrook Pregnancy and Kidney Disease Clinic and an internationally recognized authority on kidney disease in pregnancy and glomerulonephritis. And we have Dr. Gara Ankawi, who is an academic nephrologist at the King Abdulaziz University Hospital in Jeddah, Saudi Arabia. She's also the board member of the Saudi Society of Nephrology and Transplantation and the chair of the Saudi Glomerulonephritis Working Group. She trained in glomerular diseases and kidney diseases in pregnancy at the University of Toronto and in critical care nephrology in Vicenza. Welcome to the PD Exchange, and I will hand it over to Jeff.
Thanks, Nikhil. And it's been a while since we did these, and so it's exciting to, these are my last two issues of Peritoneal Dialysis International as EIC. This is the second last, and what a better way to finish than to promote women's issues in peritoneal dialysis. And today we're going to focus on pregnancy, but the issue covers a lot of different issues around gynecologic issues in peritoneal dialysis, sex disparities and outcomes. So if you haven't had a chance to look at the issue, please do. So the focus today is on pregnancy. I'm really lucky. Michelle, thanks for joining us on the podcast. To have Michelle in our backyard here in Toronto as a world expert in pregnancy and kidney disease really is a luxury because nothing scares me more than pregnancy in kidney disease. And I think it probably scares a lot of us. So we'll start with you, Michelle. I'm just curious, how did you get into this whole field to begin with?
Oh, well, thanks for having me, Jeff and Nikhil. So I guess it probably started in my fellowship. It's kind of an unfortunate story, but I was assigned a different research project that really worked out very poorly. So there was only one other research project left to complete my fellowship, and that was in preeclampsia. So when I lost the ability to do something in hepatorenal syndrome, which worked out for the best, I was assigned the preeclampsia topic. That really sparked my interest in pregnancy and kidney disease, and I've been doing it ever since. So even when my training, I was probably the most experienced person in kidney disease and pregnancy. So a lot of the patients were sent to my preceptor's clinic just because of that. So that's how I started in it.
Yeah, and there was no fellowship back then. You were sort of learning on the fly, right?
There was no such thing as coming to spend time in somebody's pre-kid clinic or OB nephrology clinic. It was just learning on the fly, gaining knowledge on the fly. And then, a lot of my research has always been in the area, so that just made it easy to condense all the knowledge in one spot. And now, the kidney disease and pregnancy clinic, the pre-kid clinic is really large, so it's a really wonderful training opportunity, which is how I met Gara, because she's actually was one of my trainees that came through the kidney disease and pregnancy clinic.
And Gara, you spent some time in Toronto, so tell us what you've done since you've gone back to Jeddah, and have you established a similar clinic? Tell us a little bit about the experiences where you are right now.
What a journey. It's been 6 years since I'm back. I can't believe it's already 6 years. It's been very interesting, very challenging, but very fun to go through. I came back with a certain mindset, so much dreams and projects and ideas wanting to accomplish it. And just similar to any journey, when it begins, you get hit by the challenges first, but then you start navigating your way through those different challenges. What I can say for the journey at the beginning really was the focus was not necessarily pregnancy, because I had few other things I had to work on as fundamentals. But as we had been able to walk ourselves through those different challenges. Now I can say the focus is definitely more on prevention, and pregnancy is one area where you can prevent kidney disease. We have been able to establish a pre-care clinic. We call it pre-care, Michelle, which is a pregnancy renal evaluation and care for hypertension clinic, which has the same or similar concept, caring for young women who has hypertensive disorders, or they've had complicated pregnancies in the past, or kidney disease that's already been diagnosed.
Right.
Or you could have also called it pre-kid GATA. That would have been okay. There's no
it's not trademarked.
no, it's not trademarked. It's not
copyright infringement.
Yes.
Well, that's great. And so it's so amazing to see, similar models pop up around the world with pregnancy care. I'm going to start with you, Michelle, because the focus today is going to be on dialysis. Here's a conundrum I've had. So you have a young woman that started and, has end-stage kidney disease, has started dialysis. I had a situation like this. The patient had lupus, and you're sort of up against a couple of factors. One is that it's going to be a while before they get a kidney transplant. At least in Canada, the wait time for deceased donor transplants is long. And if there's no living donors, that's going to be a challenge. And we know that, patients can get pregnant after kidney transplantation with stable kidney function who are doing well. And so you're up against sort of the time to get a kidney transplant and on dialysis family planning and trying to wanting to start a family. So what's your approach to that? Have you ever considered, how do you face such challenges in young women who are just starting kidney replacement therapy, who are looking for families in the future?
Yeah, well, that's actually really common. So it's not uncommon at all. We have a tendency to put childbearing off quite long now. It's very much a societal trend to wait have everything else done before we have our families. And then that puts you in a really puts many of these young women in a really challenging conundrum. They're approaching end-stage kidney disease, already on dialysis. There's no imminent donor, and now your reproductive window might be really, really narrow. So, although historically this would have never been considered something that's appropriate to do, we really do in Toronto consider it completely appropriate to counsel that you could have a baby while on dialysis if that is sort of what you want to do. Now, the challenging thing, Jeff, is also that does factor into what modality we choose. So what's not to this day understood is why it's about half as likely to get pregnant on peritoneal dialysis as it is on hemo. There's really been no good explanation for why that's the case. Also,
I have an explanation, but I'll
what's
get
your
back to that.
explanation? Do you have a good explanation, Jeff?
Okay, so here's the thing, okay? Joanne Bargman and I have talked about this. You release the egg, and then it has to be caught by the fallopian tube, right? So you've got this egg and fallopian tube, and I've always pictured that the PD fluid kind of washes away the egg. And so you're really up against the odds here when you're sort of ovulate and trying to get this egg into the fallopian tube, where this the PD fluid kind of waves away and washes away the egg. Do you buy that?
I don't know, Jeff. I don't buy most of what you say, but maybe that's okay. But most of what you say, I discredit. So no, that could be possible. Who knows exactly? But
Okay.
but it is half as likely to get. So
Yeah.
so I would have a hard time telling a young woman then you should choose PD as your modality if family planning is part of that modality picture. So
Yeah.
that pulls us toward hemodialysis to say
Yeah.
that. But it's not just regular hemo, because that's often not enough. Now, when you're just starting dialysis, you may have enough residual kidney function that allows you to get pregnant readily. But it also could be the fact that you need to do much more aggressive dialysis, and that tends to move you into the home hemo category because it's a little hard to do aggressive in-center. And in many parts of the world, it's not even possible to do sort of aggressive in-center due to resource constraints and so forth. But it is possible in a woman who's well dialyzed to get pregnant on hemodialysis. We always involve reproductive sort of endocrinology, our reproductive experts, because it's important to look to see, are there any other barriers perhaps to pregnancy that, more intensive hemodialysis is not going to fix. So it's a big sort of group discussion to sort of figure out if it's even feasible. And there's a couple things to think about. This is not just women on dialysis, but it's every woman. Pregnancy sensitize you. So is that going to make it harder to get a transplant later on in life? And, do you have the support from not only just your physician group, but also your family and everybody to manage what might be some pretty intensive dialysis hours on pregnancy? So it's a long conversation, but I do think it is one mechanism for women approaching end-stage kidney disease to have the hope of still having a child is doing it on dialysis.
Yeah, so I think that's a really important point. Then when we're talking about modality and we're doing modality education with young women who may be thinking about having a family, that we really definitely make sure that we're educating about other, options, including home hemodialysis. And I think if, Michelle, correct me if I'm wrong, if you're going to go home, it's more of an intensive schedule. I mean, there's no point to do home 3 times a week for 4 hours in this population. There's got to be that understanding. And, you and Chris Chan have done quite a bit of research on the outcomes of more intensive dialysis. Do you want to tell everybody about those outcomes?
Yeah, so we didn't really know, honestly, many years ago that fertility improved with more intensive dialysis because the first women in the cohort were women that weren't getting pregnant on conventional, never thought they could get pregnant, then switched to intensive nocturnal, and oh my goodness, they got pregnant. So first, that was the first thing that I don't think was well understood by Dr. Chan or me, that the intensive dialysis was going to improve fertility. But we do have quite a bit of data now to suggest that so long as we do pretty intensive dialysis, and intensive dialysis we do now understand is not the same prescription for everybody. It's sort of like, what do you need to keep you almost physiologically sort of healthy and normal? And that results in really good pregnancy outcomes. The live birth rates are not different than transplantation. The gestational age, based on a recent publication we did, is also not that different than transplantation, but the babies still remain smaller. So that actually just comes from a publication that we just published a few months ago. So it is possible. It just requires quite a bit of time and investment on mom's part.
And I think the flip side is true for women that are going on to intensive dialysis who choose not to get pregnant. There has to be some education as well. Because surprise!
Surprise. Yes, you have to be educated. If you're not wanting or desiring a pregnancy, these women do need a method of contraception for sure.
Yeah, and I think in general, one of the things that I think people overlook, even when starting PD, is women can be quite uremic before starting dialysis. Then they start PD and they start to get their menstrual periods back. And one thing that I think can really freak somebody out is to wake up one morning and look at their drained effluent and see it as a bag of blood. And, sometimes I'm on the social media groups and, every month someone will post a picture of this and freak out. But I think it's important, as a PD practitioner, to warn people that when they're going to start dialysis, particularly young women of menstruating age, that they may get hemoperitoneum and not to freak out when it happens that time of the month. I think it's something that people don't often do education enough around the time of starting dialysis. I'm going to ask Gada, have you had an experience with pregnancy and dialysis in Saudi?
There are cases of pregnancy on dialysis in Saudi Arabia, but majority are really within the territory of hemodialysis and not peritoneal dialysis, just like everywhere else. Again, majority of patients are in-center hemodialysis because one of the challenges to start in Saudi is the acceptance of the idea of performing dialysis at home altogether. This is with pregnancy or without pregnancy. People tend to prefer in-center modalities. So yeah, when it's happening, it's mostly hemo and it's mostly in-center.
Well, I know that we are training a number of people here that are going back to Saudi to establish home programs. We sent to Jeddah Dr. Ahmed Makeen, who's gone back last week. So maybe you two can touch base about promoting more home therapies, particularly home hemo in this context.
Yeah, I think we have a lot of work to do with our patients, to be honest. It's definitely something that is very appealing to the physicians, to the nephrologists. We're very much into the idea of promoting and establishing home-based programs. But I guess our patients would need a bit of more support maybe to the idea that this is really should be done more often.
Yeah, and so I was going to ask you, Michelle, in a case where someone in center, let's say, gets pregnant, obviously training for home, going home is something we can do proactively in someone contemplating a pregnancy. What do you do then in there? So boom, you get the call from somebody, one of our in-center patients has just tested positive. Tell us how you go through that.
One of the things you want to be careful is if one of the early diagnostic signs is like worsening anemia and increasing EPREX requirements, because that could mean that she's actually pregnant. So you should check a pregnancy test. I think that really brings to the discussion something really important, and that's equity. So not everybody has the resource or has the home or has the what is necessary for home dialysis.
Yeah.
So I think it's really important as well to have a cooperative in-center sort of network. We obviously, it would be much easier on her as well if she could do it in the comfort of her home. Sometimes you need up to 6 hours, 6 times a week, which is a really long amount of dialysis. It's also very arbitrarily chosen because that's actually like 4 shifts kind of thing. So it's kind of an arbitrarily chosen number, but not everybody can go home. So, we're very lucky in Toronto where when I have a pregnant woman, the in-center dialysis units will accommodate, if necessary, in-center dialysis. I think one of the most heartwarming stories was actually up in the Barrie area where a young woman, actually, no, she was in the Sioux, and a young woman got pregnant on dialysis. And, they really do have a constrained ability to offer that number of hours based on their in-center schedule because they don't even run every day. And two of the nurses just volunteered their time to come in on Sundays to do that extra dialysis that she needed. And she had 2 healthy babies way up in northern Canada. But it does need that kind of support from in-center units. We've even had to do it where more than one unit collaborated to have a pregnancy in Toronto. So, for example, for many years, only some of the programs had in-center nocturnal, which is really helpful to getting enough hours on dialysis. So women, for example, would do 3 nights in-center nocturnal in one center and again in another center, or they would come after work to UHN because they work downtown. But then the other days when they didn't work, they do it at Sunnybrook. So we've worked on some very unique collaborative ways of making that happen. But then it really begs the question for like so many women in countries that really can't intensify dialysis. They're just lucky enough to get dialysis. This is not really something that's an option for them, is to have sort of a healthy child on dialysis. And we do know that if you don't provide enough hours of dialysis, the live birth rates can drop as low as 50%, right? So this really talks to a really significant part about equity.
Yeah, and certainly residual kidney function obviously has a big role to play in terms of how much dialysis is needed. Tell us about the monitoring of somebody, be it on intensive, in-center, or home, who's pregnant. What are some of the things that we need to know would be different in terms of looking at dialysis monthly labs, dry weight adjustment, those sorts of things?
Yeah, so most of it actually stays pretty similar. Like, you're still going to do monthly labs. You may do them a little bit more often just to make sure that everything is sort of stable on dialysis. So the biggest change, I think, is the dry weight assessment. It becomes really challenging to do a dry weight assessment, so it becomes very much a clinical decision to understand if you're taking off enough fluid or you're not. The biggest risk is actually hypotension on dialysis because there's no autoregulation to the placenta. So if mom really drops her blood pressure on dialysis, that's quite concerning. So for that, it's really all about training your nursing staff, right? To really pay attention to the blood volume, pay attention to the blood pressure, and maybe stop or back off ultrafiltration if there's the potential for, mom to drop her blood pressure. I think that's actually our most important collaborator. And then it's the nursing staff that is doing the actual dialysis. And typically when someone's gotten pregnant, say, I don't have to do this as much now. People are becoming more knowledgeable about pregnancy on dialysis, like throughout Ontario. But in the early days, I would even go out to do a talk, like as far as Thunder Bay. I went one time for a pregnant woman on dialysis, just so we made sure everybody was truly, knew what they were going to do in terms of managing her safely and monitoring her carefully. The obstetrical management happens at, one of the high-risk OB sites because that's a whole other management in and of itself that we can discuss. But the nephrology management can be done closer to home in a collaborative way with nephrologists and nursing staff that have maybe received a little bit of education just so that everybody's really aware how to manage her on dialysis.
And so things like, correct me if I'm wrong, amniotic fluid volume can be very sensitive to dry weight adjustments, correct? And so have you often had to adjust it based on ultrasounds showing either too much or too little?
Yeah, so polyhydramnios, which is too much amniotic fluid for our nephrologists there that don't remember their medical
Yeah,
school.
I forgot.
Oh, did you forget? I thought so. And Nikhil's smiling though, so Nikhil knows what he's doing. It's just forget and everything. But so that is something that can come from either inadequate ultrafiltration or inadequate dialysis, because it's actually the uremia that causes the osmotic sort of diuresis and makes baby sort of pee more, and that results in the polyhydramnios. So so the things that we're watching obstetrically, then very careful in this population, is the amniotic fluid levels that can tell you how to adjust your dialysis prescription. But the other thing is also cervical length and competency. And for reasons we don't understand, and it's just, maybe it's also, I have no idea why it happens, but seems to be a higher rate of cervical incompetence in the dialysis population. So now we are very aware of it. Earlier on, we were not, and it did result in pregnancy losses. But now that we're so aware of it, cerclage may be something that we're offering sort of earlier than later. Why that happens, I have no idea. I'm sure, Jeff, you have some fine physiological explanation for it, like the washing away the eggs, but I don't.
No, I am incompetent, pun intended, in that regard.
I have a question, and especially with the recent paper also in that issue, is about a patient on peritoneal dialysis who could not or would not switch to aggressive in-center or home hemodialysis. How do you counsel them? And I'll ask Gara this question first, and then Michelle. Gara, how do you counsel a patient, if there is resource limitations or they cannot? How do you start discussing this as we go forward?
I think the key is to understand where are they coming from? What's their concern about switching modality? Is it concern about not being able to go back to that modality, for example, once the pregnancy is finished? Because once you understand their concerns, you understand where they're coming from, it's counseling and talking to your patient and getting them the best option becomes much easier. And we've had cases like that in Saudi that we've been managing remotely with our colleagues. And the concern was exactly that, the woman not being very concerned that she wouldn't be able to go back to PD if we were to switch to hemo, for example. And the way we had approached this is to kind of gradually do it. We were able to do hybrid between the two modalities for a while until it became really challenging for her to continue the PD. And then we were able to switch to hemodialysis later in pregnancy. And she had a successful delivery at 35 weeks, and she was able to go back to her PD as a modality. So I think the key is really to understand their concern, and then you'll be able to explore it with them and see how you can offer them the best approach.
So there are case reports throughout the literature of people having successful pregnancies on peritoneal dialysis. They're just fewer. Okay, so she already got through the hardest part where she actually conceived on peritoneal dialysis. And truly, at least for the first and the second trimester, there shouldn't be really any concerns continuing on peritoneal. And we've done that for women that have lived remote, especially remote communities throughout Ontario. There's a really wonderful case did in Alberta as well, Nikhil, where the woman did just live quite a bit, quite remote, and it was really challenging, and her home wasn't set up for in-center hemo. And honestly, she'd be away from her family if she had to move to Edmonton or move to Toronto just to continue dialysis throughout the pregnancy. So certainly for the first 2 trimesters, it can work extremely well, peritoneal dialysis. When it gets a little bit tricky is when the baby sort of grows and then there's not as much room and you're continuously then dropping your fill volume in order to accommodate sort of a growing fetus. And it's then that sometimes you might need to supplement with hemodialysis. But again, sometimes our peritoneal dialysis patients also have a lot of residual. So they might get away with these lower fill volumes later in the pregnancy. We just need to watch them carefully. So these cases have to be pretty individualized. There's no one size fits all. Now, what we know from the literature is you're half as likely to get pregnant on peritoneal and you're twice as likely to have a small for gestational age baby. So how do you get away from that? Later complication is going to be with careful monitoring, with careful assessment. Honestly, if she doesn't have enough residual to get her through those final stages of pregnancy, then those are the patients that might need a hybrid sort of form of dialysis or, not sort of use PD towards the end. But again, it has to be completely individualized. And then there's so many areas of our world where intensive hemo is just not it's just not logistically possible. So we have to have a really open mind about, women getting pregnant on peritoneal dialysis. So I wouldn't necessarily switch them right out to, like I think if somebody said I can do either and, then sure, let's switch you to nocturnal or aggressive, hemodialysis. But if we can't do either, then there's a lot of ways that you can carry pregnancies through so they have the best possible outcome.
I bring this up because in my fellowship in home dialysis here in Edmonton, we did have, I was exteriorizing a patient, and it was, then they brought it up that, oh, they're pregnant. And then I was like, oh, okay. I just exteriorized the patient, start PD, and they're pregnant. And there was a big discussion, a family discussion. And this is where the shared decision making comes in. This was a very, very early start, and they carried it through on PD throughout. So that is something to consider.
Yeah, I think you called me about that case.
I did.
So I remember.
It was a CSM poster. Like
I remember that quite well, but that was a perfect example.
Yeah.
She was an early start for PD. She had a lot of residual, so it was possible, even though the fill volumes had to drop at the end of pregnancy overall. And there was a lot of discussion about what would be best for her and her baby. And, the shared decision making for her family was really critical to allow her to get through that pregnancy. So good example.
Did it end on hemo?
No.
No.
She ended on PD and she did really well.
And I have a card. I have a card with the baby's picture.
Wow.
And Jeff, that's the best part about this is like, I still get pictures almost every year of babies that have been born on dialysis. I think the one that I hold dearest to my heart is a set of twins. And I just got their high school graduation picture, and that's really rare. I think I've only taken care of one set of twins my entire career on dialysis, so that's a super special case.
Well, as one of my mentors once said to me, there's two happy reasons to come to the hospital: to have a baby and to have a transplant. So that it is. I'm sure you've got the gallery of baby pictures in your office. What an amazing joy to celebrate with our patients. But Nikhil, the case you mentioned that you personally had, and that in PDI, I think it's really important. And I want to emphasize this to our listeners that, I do think residual kidney function does modify the outcomes. And not that it's been formally studied, but of course, your case was a person brand new to PD. So of course they had to have sufficient residual. And if you read the case report, one of the case reports, there was a lot of residual kidney function. It almost, to the point where, I think there was just very little in an era where we're all practicing incremental dialysis. If this person wasn't pregnant, it wouldn't have taken a lot of PD for that particular case report. So it is worth mentioning, when we say PD is possible and, we can continue on, how much residual kidney function modifies our approach. And if you think about it, if the fill volumes need to decrease, and if someone doesn't have a lot of residual, it's almost, in the third trimester where you probably need to ramp it up a little more with dialysis, and you may be struggling. So I really like what Michelle said about emphasizing an individualized approach.
Yeah, and it actually has been studied. There's an old paper from Australia where they actually looked at pregnancy outcomes based on how much residual patients had. And there's no question that the residual kidney function significantly improved pregnancy outcomes. So certainly that does make a really big difference. They compared those with no residual to those with residual, very similar dialysis modalities, and that residual kidney function, although it seems so minimal, still made a pretty significant difference to pregnancy outcomes.
Is preeclampsia more challenging to diagnose in end-stage kidney disease?
So certainly, it is because, you're looking at, worsening hypertension. You're looking at, changes to urine protein. There may be no urine to look at. And then you're waiting for, symptom, HELP syndrome to evolve, which you don't want to be doing. You don't want it to get that far.
Yeah.
But now what's made it a lot easier is we do have the anti-angiogenic markers. So we use the soluble FLT to placental growth factor ratio quite often in Canada. and to help us diagnose if somebody's developing preeclampsia. Actually, I have a great story in one.
Is it like a placenta troponin? That's
It's
how
a
I think about
placenta
it.
troponin, my placenta
Okay.
troponin. So I have one of my best stories of one of the dialysis patients is she came in at about 28 weeks gestation. Her blood pressure was really quite challenging to manage. And honestly, if you're just looking at her, you think she's evolving towards preeclampsia. But I wasn't sure I was getting the dry weight right. I wasn't really convinced we were taking enough fluid off. So anyways, we did the ratio. It was 0. The ratio was actually 0. So, I said to the obstetrician, give me a little more time. Let me try to control her blood pressure. So within a week, we took off a little more fluid. We put on some blood pressure pills. She ultimately went to 36 weeks gestation, right? So I think if without that ratio, just to make everybody feel a little bit more comfortable that we were actually clinically considering the right things of too much, fluid on board, et cetera, I think she could have ended up with quite a preterm birth. And it can't take away your clinical assessment of a patient, but it can really help you as part of, that complex assessment. So I'm a big believer in it. In, the ratios, I find them extremely useful in my practice.
So that's a good point. So like, unlike troponin, which sometimes can be like sort of chronically elevated in our patients, is this going to be 0 even in dialysis patients if you're tracking them along, as in the case?
Yeah, well, you have to be a little careful. I don't think we have enough.
There's your
In her
study,
case,
Michelle. You got to do a study.
In her case, we're doing it as we speak, Jeff. It's not like we're not doing it. So one of the things to consider is the ratio is soluble FLT1 to placental growth factor, and placental growth factor is renally excreted. So you could get some sort of falsely elevated placental growth factor. That's why, at least in my opinion, I prefer the ratio in the renal population.
Yeah.
And we did study it in sort of 100 women, but with CKD, not with end-stage kidney disease, and it seemed to perform a little bit better than placental growth factor alone. But we're actually now studying sort of a number of different methods of looking at those biomarkers. So we should have more data soon in terms of comparing them all in the CKD population.
Right. Okay, so this has been really helpful. Nikki, I think you were going to ask something.
Yeah, I was going to ask Gara about this. Is you set up a new clinic when you went back to Jeddah? How did you go about, we were talking about CKD and monitoring and all of that. How do you set up something if a nephrologist is interested in doing this in their own centers? How do you go about it? Do you have some direction?
Well, it really has to start with collaborating with your OB team. This would be the way to go because it's not even that clinic. If you're doing a clinic, for example, on your own, and you're not involving the right people who are actually the frontliners or the people who actually see these ladies, whether pre-pregnancy or postpartum or during pregnancy, then that clinic might not work. So the first step was really involving the OB team, talking to them, approaching them, presenting what we believe should be the way to go. And honestly, using the analogy of pregnancy as an opportunity and as a window to diagnose undiagnosed disease and to prevent progression, et cetera, and this had worked out very well. The reason we called it pre-care, and I should emphasize that, is we're still very early in implementing the idea of kidney disease in pregnancy. So I figured if I use hypertension, at least it's a more common concept and a disease that is more commonly seen, and maybe people will be more invested in using that clinic, referring the patients, and hopefully we can help as many people as we can.
That's a great idea to set it up for success in the long run, right? You start slow and build it up.
Yeah,
and
one step at a time.
Yeah. That's fabulous.
Absolutely.
That's fabulous.
And
you mentioned something I wanted to ask you, Gara, and then ask Michelle about that collaboration with OB. I think that's really critical here. How have you made that work? What advice would you give to others in terms of starting something in the collaboration with our OB colleagues?
For me, just building the case. Every time I come across a lady who was diagnosed or picked up or because of being seen or worked up during pregnancy, I just have to make sure that this case, everybody knows about that case in the hospital, for example. Just recently, we've been emphasizing the postpartum follow-up, the importance of not losing patients once they deliver. And we had exactly that. A lady who delivered had lingering proteinuria. Somebody was super vigilant. They continued to follow biopsy 6 weeks postpartum, and boom, she newly diagnosed IgA nephropathy. So that case, I have to make sure that everybody knows about that case. Unless you do that, people may not see the other side of the equation, because they see their part, but they don't necessarily see our part when we pick them up later or years afterwards with established kidney disease. So just by raising awareness as much as we can, be it by talks or personal communications or.
And Michelle, in your model,
Mhm.
you obviously Sunnybrook is a high risk OB center. Are there like groups of OBs that specialize in certain high risk areas, like high risk autoimmune, high risk neurology, high risk, like, do you have your like high risk subspecialized kidney OB people?
Yeah, so I've been doing my clinic with the same obstetrician for 20 years. So she's taught me a whole bunch of fun things about placental Dopplers, and she can actually interpret proteinuria. So we're like we're already a step ahead of everybody else. But yeah, no, we actually do have a designated clinic, and we do the clinic. We don't see every patient together. We do the clinic at the same time so that, we can have the hallway discussion of like, whoa, we're losing kidney function here. This is getting really concerning. What is the delivery plan? And this happens with every sort of single really high risk patient. So it's very helpful. Now, sometimes when there's really terrible news to deliver, or we're really concerned about a patient who's deteriorating, then we have the opportunity to sort of go in together and present the renal, concerns and the obstetrical concerns. So, the combined clinic with an established obstetrician in the area is what's, I think, made it really, really successful at Sunnybrook. That's not always possible, but at least if you have sort of a smaller group of individuals that are particularly dedicated to the renal population, it starts to, that expertise on both sides starts to develop, and it improves patient care.
Yeah. And then in that clinic, I mean, you guys have alluded to having to give bad news and, a lot of shared decision making, a lot of discussions, a lot of difficult discussions. Do you have access to social work? And has that been, what other allied health have been a part of that clinic that you see as really instrumental?
So, social work, absolutely. We have social work support in the clinic, and that is really, really critical. We have MPs as well, because a lot of the care happens between the clinics. So they're going to start monitoring their home blood pressure because we're worried about them evolving or deteriorating. That nurse is going to develop the rapport with that patient and be in very close contact, even between clinics. So she knows when to come to triage, when to reach out to us. So nursing is very helpful. And we do use pharmacy as well, because some of the medications that we use are, potentially, teratogenic. We're going to be, we're just putting together a paper now how ravulizumab actually crossed right into the cord blood and suppressed the baby's immune system. So we're just putting that together right now. So it's really helpful also to have pharmacy available to have those discussions with patients about drugs and safety. And it gives the patients a lot of, peace of mind to know they've discussed it with somebody as well.
Yeah.
So really all members of the multidisciplinary team are really important. And then once you're on dialysis, nutrition becomes really important as well. So our dietitians are also very involved. So all the same, members of the team that we have taking care of the renal population are also there within pregnancy as well.
Couple quick sort of rapid fire housekeeping questions just because of my curiosity. Everybody gets aspirin who's pregnant on dialysis? Yes?
They do, but we have no evidence to know whether it makes a difference or not. That population has never been studied. I think we give it because we're extrapolating from other studies, and it seemed, and of course aspirin is quite safe. Whether or not it actually makes a big difference in the dialysis population is simply
no idea.
No idea.
Do we double up on the vitamins because of the losses, or similar doses to non-dialysis pregnant patients?
So we have a tendency to give a little bit more vitamin. Again, if that's completely necessary, it's unclear. We've had some of our RDs say that's unnecessary, but many of them are water soluble, so they do remove. But I think if somebody has a decent diet, it's probably fine to continue the usual dose of Replovite. Some of these women, though, can be really nauseated. They're not eating well, and then you have to think a little bit about vitamin supplementation.
Okay, and then two more questions. Do you see EPO requirements and ESA requirements go up?
Way up. And you
Yeah,
better stay on top of that because, I would consider it a failure of care if I didn't keep up with iron and EPREX and I had to give somebody a transfusion. So now there's two sensitizing events, a baby and a transfusion. So,
yeah,
you really need to watch the hemoglobin. The EPREX requirements go up significantly.
yeah.
And you have to make sure you're giving them enough IV iron as well. So if you fall behind, they actually can become really anemic. And then you're setting them up for sort of a dangerous delivery or the need for a transfusion prior to delivery. So I consider that a little bit of a failure on my part of management if I didn't keep up with that adequately.
Yeah, and then the other thing I was going to say is if you do go down the intensive dialysis route, hypophosphatemia and calcium balance probably becomes something that needs to be on our radar. Wonder if you could comment on that.
Yeah, they both need to be on your radar. You don't need dietary restrictions when you're doing intensive dialysis during pregnancy. So there's a lot of wonderful ways to increase your phosphate as well, like, pizza and ice cream and so forth. But if you can't manage that, then sometimes we're adding fleet to the dialysate. So all those things need to be watched very carefully.
Yeah, the pickles and ice cream are a reasonable combination.
Says the guy who's never been pregnant. That's just
No, but I can tell you, I have sat through for my twins, who one of them was not growing, was not behaving and not growing well. I sat through 555,000 ultrasounds and cheese to get that cerebral artery Doppler result and that placental Doppler. And I actually would tell the technician, "No, you got to move the probe over there," because I had sat in so many ultrasounds.
Yeah, but did the pickles help?
The pickles help me. Pickles always help me.
So this is a question for both of you. W- how do you counsel a patient who is now successfully delivered and going back to their regular dialysis? What is the next step? Do you counsel, okay, you have the baby now. Now is the time for contraception. And have you ever had a patient who has a second baby on dialysis? So Gada first and Michelle next.
Personally, no, I have not had someone who has two kids on dialysis, but I don't know what Michelle's take on it. But my take on it is good luck. You could counsel as much as you can, or as much as you think you need to, but eventually they'll surprise you. And that not just with patients on dialysis, it's also applicable to people on who has GN or CKD or transplant recipients. They would probably be engaged and involved, but at the end of the day, if they desire pregnancy, they'll just surprise you with the second and third pregnancy. And that's certainly very, very common in the GN patients. But yeah, you have just to sit and explain and why we think it's a good idea versus not. Shared decision making, letting them state their wishes and trying to understand. But they'll probably come back if this is something they desire. They'll still come back pregnant.
So I actually have quite a few that have had multiple children on dialysis. One of them had 3 children on dialysis. And you kind of might ask yourself, well, why is that happening? Well, these women were highly sensitized already. So they weren't going to be getting a transplant imminently or ever, right? So they decided to have their entire family while on dialysis. But, they've proven fertility. So we always discuss what type of contraception. So these pregnancies can be timed. So that's something we have a discussion with after each delivery. But one of the things that is really, I think, the hardest part is, these are high-risk pregnancies. There's so much anticipation. There's so much attention on these pregnancies. And all of a sudden now you've delivered. And these are still really high-risk moms. And they're tired. And they have to have small children now at home. Some of them already have other children, and they have to manage that in the context of living on dialysis. So a few things that those who have the potential for transplant, we really work hard to, get their workup done, make sure they get that transplant, get off dialysis as quickly as they can, while they have a young child, because it makes it a lot easier for them. For those that don't have transplant, that's when our social workers really do step in and provide a lot of support. And sometimes it's easier to go back to conventional dialysis. Sometimes it's also easier to come back in center and let us take care of you for the 4 hours, 3 times a week. but everyone's a little bit different. And again, that needs a really individualized approach. And you really need to talk to them about how best to support them now in this really challenging time. For those of us who have had a child, it's really hard. Like I found my children more difficult than residency. So, if you also have a small child, and then you now on top of that have, you still have a need to be on dialysis. So there's a lot of support that has to happen in the postpartum. I think it's important to mention breastfeeding because there's nothing preventing these women from breastfeeding. Okay. And sometimes you read a paper about they're checking the quality of the breast milk at different times. Oh, breastfeeding is hard enough. So it doesn't matter if there's a little bit of urea in the breast milk. It's not going to matter one bit for baby. So these women can breastfeed. They can have that experience. It is challenging. And again, they need the support.
Yeah. Obviously, I think the message is one size doesn't fit all. And it's all about the support that's around. And God, I have to share something. Culturally, in the Middle East, I know a lot of my friends who've had kids, the first 40 days is sort of a support mom period, correct? And culturally, family gets together and helps people who've just had pregnancy. Am I right about that?
Definitely, definitely, yes. Family support is a big chunk, and it is quite helpful because, as Michelle just mentioned, it's a tough period in a normal pregnancy, let alone in such complicated pregnancies. So it actually comes in handy.
Yeah. And it does make sense to revisit home
Very
versus
true.
in center, as Michelle said, and PD and all different options. Try to get kidney transplant up and going as quick as possible. So all of that makes a lot of sense in terms of having those discussions. Well,
Yeah.
I have learned a lot from this short 40 minutes here. And I think this has been really great. I hope our listeners out there are thinking about if they don't have local expertise in CKD and pregnancy and dialysis, to think about developing that. And of course, it's going to require some thought about what local resources you have. And we've heard from two exceptional clinicians and nephrologists today about how it can be possible and how to provide multidisciplinary care to our patients. And Nikhil, any final questions or thoughts to our speakers today?
No, this is exceptionally important and exceptionally lovely to have both of you here to talk about pregnancy. So thank you for that.
Well, thank you for having us.